on these 5 objectives, we're gonna spend a lot of time on objective. So that's the heaviest objective in this section. The big thing about some of the other objectives is knowing how to take care of the patient. And when I say take care of the patient, I usually mean mom, baby, and the family. Okay? So aversion. Aversion is when the baby is breech. It's usually one baby, that's what singleton means. And where the physician is trying to turn the baby from breech to vertex. Breech to vertex. So in this situation, the baby cannot be engaged. Aww. That just means that they're not in the pelvis. So again, I can't be at 0 station, I can't be at a positive number, because the presenting part is already engaged then. The other thing is the bag of water cannot be broken. There needs to be enough amniotic fluid there to be able to manipulate and move the baby around without causing cord compression or complications. So we need to make sure that there's an adequate amniotic fluid index. You also want a non-stress test. So some providers will do a biophysical profile on the baby prior to doing aversion, because that biophysical profile is a baseline to say, this is the status of the baby at the time I did the version. So the version is only for babies who are breech. We're trying to turn them vertex. And so performed around 38 weeks. And again, that's a little bit, you know, we used to do them at 36 weeks. You keep getting later and later with them. 37, 38 weeks. It's kind of a fine line because the baby gets bigger and we'll start to get, because we have lightning happen where the baby gets engaged and drops down lower. So it's a very specific time window, and sometimes the version does not work, but to try and turn the baby and keep the baby vertex. So these would be reasons not to do aversion. Not to do aversion. So if your patient is scheduled for aversion, but the bag of water has broken, she is not going to get aversion. Okay? So let's take a look at this list. Is there anything up there that you don't know what it is that we need to chat about? Kind of fuzzy on? In other words, these would be reasons not to do aversion, contraindications.
For previous C-sections, that's just probably going to get another one.
So previous C-section, the concern is that we already have scar from the previous C-section, so if I'm pushing really hard on the uterus, I put her at risk for uterine rupture. She could still, so let me, let's say if she's a previous C-section and she's breech, the OB provider's probably gonna say, let's just do another C-section. If she's a previous C-section though, that doesn't necessarily mean that she will be a repeat C-section. Not all previous C-sections are repeat C-sections, because you may have a vaginal birth after cesarean or VBAC. But if she's breech, she had a previous C-section, because if you ever see a video of it, I think I might have one in those, but if you, I mean, they really push, and you don't want to pop up in that scar. You okay with nuchal cord? So nuchal cord would probably be seen on ultrasound. We would, that's not something you'd get from vaginal exam, but we'd see like a cord around the baby's head, because again, I can't, the provider can't get the bottom up towards the fundus and the head towards the symphysis pubis if there's a nuchal cord.
Why wouldn't you do it if there's like intrauterine growth restrictions, if they're already small?
So there's already some problem with perfusion, like there's the baby doesn't like the apartment. And so to put stress on that could put the baby into stress. We don't want something that we do to kind of tip the seesaw toward fetal distress. Because again, we have another option, which would be C-section. And if it doesn't work, she's going to be a C-section.
Would the third trimester bleeding be like bright red blood and excessive?
Yes. So usually with third trimester bleeding, there's something's not right with the placenta, and so that again we don't want to disrupt that, because our concern is that maybe the cord insertion is bad, and I again by manipulating that baby, it's going to put the baby into stress. I do have a video version, and so the video I selected, it's from the UK, And the patient has this really bizarre look on her face, and you can just see it. It's really short, but it's a pretty good representation of aversion. Lately in our community, we are seeing more of our providers do epidurals for patients who are getting versions, so they're not as uncomfortable. Some providers disagree with that because they want the patient to have feeling and sensation to know how hard they're pushing, so they don't push too hard on the uterus. Because again, if you push really hard on the uterus, it could break the bag of water, it could cause uterine rupture. Folks, it's kind of like most things, you know, you want the person doing the cardiac cath who does a lot of cardiac caths, you want the person doing a version who has done a lot of versions. Unfortunately, in my neck of the woods, we often are the place where residents learn how to do versions, so sometimes they don't always work. So some things to think about as a nurse. It is an invasive procedure. It's done in the hospital. We tell patients to be prepared that if there is a complication that she'll stay. So it's not something where you get a version, you can go back to work by noon. I would take the whole day off from work, and the idea is you may be coming to the hospital and you may be staying because you may not be leaving, and you may be leaving with your baby. So that's the other reason we want to do it closer to term. Now, if they did a version at 36 or 37 weeks, again, more than likely, baby's gonna be okay, but a little bit earlier, so a little bit more difficulty with thermal regulation, may have some difficulty with meeting its oxygen needs on its own. But again, we're kind of trying to wait and do those a little bit closer to 38, 39 weeks. She does need continuous monitoring. As I mentioned, they might do a BPP. We need to have IV access, and a lot of times we're giving IV fluids. So the medication that can sometimes be administered with a version is called terbutaline. And you might know this drug by its brand name called Breathine. In Med-Surg land, it's used for asthma. But in OB land, it is not used for asthma. The reason we give it in OB land is to relax the uterus. And so we don't really want her having contractions. When we're pushing on the uterus, we want the uterus as relaxed as possible to be able to get that baby to move from breech to vertex. Now, if I give terbutaline to the mom, it is a beta adrenergic agonist. And so what it does is it causes muscle relaxation. It stimulates the sympathetic nervous system, and so you see a heart rate in mom go up. So we wouldn't want to give Breathine or terbutaline to a mom who's already tachycardic, because it's going to make her heart too fast. She'll have palpitations and she'll have distress. But when you give terbutaline to moms, and usually in this situation, we probably would give sub-Q. We wouldn't do PO. But moms will talk to you and they'll say, I feel real jittery and real shaky. And that's very normal. That's the terbutaline working. Pain management, again, in some cases, the patient gets nothing for pain. In some cases, the patient might get an epidural or spinal. In some cases, they will actually admit the patient, and then they'll do the version, and then they might try and actually induce labor if it's a successful version, because the baby's head down, and they want contractions to keep the baby head down. If they try and they can't get the baby turned, then that's considered a failed version. It's not anything mom did, but then the patient will be a C-section. And sometimes it's the same day. Sometimes they have the patient leave and go home, and then come back when there's a scheduled section. It just depends on the facility.
If the patient said like, oh, I had a family version or whatever, can you clarify that? Are we allowed to tell them that chances are they're getting a C-section or no?
Let me give you a clinical example. You have a patient who comes into triage. She said, I was a failed version last week, and I'm in labor today. I very much would want somebody to do a bedside ultrasound on her very quickly to see if her baby is breech. Because even if she's in labor, if she was a failed version, the baby may have moved on its own, but more than likely it didn't, and even though she's in labor, she's gonna be a C-section. But she leaves when she'll know right away with this procedure if it worked or not. It's not a surprise, it's not, let's wait. So they'll be able to say, yep, the baby looks head down. I've even seen some people, they've put abdominal binders on mom, trying to get the baby to stay. Because some of these little babies, they are Houdinis. And it's like, they're just a lot more comfortable going back the other way. And it's like, nope, we want you to go this way. I've seen, again, working with different providers, different things recommended to try and get the baby to turn. So for example, like trying to lay in Trendelenburg, to see, like, let's say she's 36, 37 weeks, trying to lay in Trendelenburg to see if that will get the baby to move. I don't know if I haven't seen any evidence to support that, and sometimes it actually causes some symptoms in mom, like if she doesn't feel well and things like that, so, but I do know some healthcare providers seem to think it really works, and it's, so I think, you know, again, it depends. You had a question?
Oh, I was just wondering if after a successful version, the baby would have flipped back around.
It does, and so that's another thing, if your patient came in and said, yeah, I got a version a couple weeks ago, same thing. I would do Leopold's, and if I got heart tones really high in the upper quadrants, I'd be like, "Ugh," but they would do a bedside ultrasound to see the position of the baby, absolutely. So after the procedure, again, kind of uncomfortable for the patient. We usually keep mom on the monitor, baby on the monitor. We want a reactive non-stress test. If we're gonna send her home, we want a reactive non-stress test before we ever send her home. We check her vital signs. We're watching for ruptured membranes, bleeding, and contractions. So we're concerned about labor status. So again, she has the TOCO and the ultrasound. So let me ask you this. You do a version. Does the patient need an IUPC or a scalp electrode? You don't think so? Usually not, because remember, IUPC and scalp electrodes are invasive. And the water has to be broken, and if the water's broken, I'm committed to delivery, like I'm not sending her home. Now, why would they put an IUPC and a scalp electrode in? There has to be a reason for it. It's not just routine. It's not healthy moms and healthy babies, they just don't get IUPCs and scalp electrodes in labor. So no need for any of that with this procedure. External, so you have two belts, you have the TOCO that looks like a button, that goes on the fundus, and then the ultrasound measures the fetal heart rate, and that goes in the lower quadrants. It should be on fetal back. All right, cervical ripening agents. This is a confusing concept, so this is a good one to finish up on, so we'll revisit this. When I think of cervical ripening agents, the word that sticks in my head is effacement, okay? So these things will help with effacement. Now, why is it confusing? Sometimes what happens is they soften the cervix, they help improve effacement, but it kicks women into labor, okay? But these agents are used when the patient's cervix needs to be ripened. And what that means is that it's long, it's closed. We need to soften the cervix and shorten the cervix. So remember our balloons? When we started out, they had a nice long neck. They need Cervidil, Prepidil, Cytotec. They need a Foley catheter balloon, and that balloon presses on. So I don't know if any of you guys had to kind of take your fingers and kind of push against the sides to get your ping pong ball. That's kind of what a catheter does when we use a catheter for mechanical cervical ripening. There's no hormones or anything associated, but it's the pressure of the balloon up against the cervix that makes it soften and open up. Now, that's mechanical. So mechanical, no hormones, low risk to mom and baby. Not the most comfortable thing in the world. Anytime you're messing with the cervix, it hurts, okay? There are medications that we can use, Cervidil and Prepidil. So for me, because I can never remember, and I think it's because I'm used to using Cervidil. Cervidil is the gel by itself, and I think Prepidil is the medication in like a tampon with a string. I may have it backwards. One has a delivery system like a tampon, so it's like a little gauze and it's saturated with the medication. The other one is just the medication, there's no string. They are both prostaglandin gel. It looks kind of creamy, like hand lotion, and it's inserted usually by the provider, sometimes by the nurse, vaginally, up against the cervix, and the whole idea is that gel kind of lies up against the cervix, and again, it's gonna cause the release of prostaglandins, which are gonna soften the cervix. So I don't know if you guys have ever taken a hard stick of butter from the fridge and it's really hard. If you let it sit out long enough, it softens and it's easier. That's kind of what we're wanting this to do. We're wanting it to soften like butter. So a gentle process. Again, sometimes it causes some cramping, but if you ever have a patient who's on Cervidil or Prepidil, it's probably going to be a quiet day. There's probably not going to be a lot going on. The patient's kind of taking it easy, so we want her to rest and relax. Because sometimes it can be 8-12 hours before we really see anything happen. Why would we do these things? We use less Pitocin when we use these medications, which is a good thing. Pitocin has side effects. Pitocin has risk. And so if I can get away with using less of it during labor, I want to do that. These have the same side effects though in terms of Pitocin. So they can also hyperstimulate the uterus. You can cause baby distress and you can cause uterine rupture, but you're less likely to see it with these medications compared to Pitocin. So I'm going to say that one more time because I'll say it super fast. They have the same risks as Pitocin, but you're less likely to see them with these cervical ripening agents. The other thing is think about when we're giving them, because we're giving them when she's not in labor very early, so there's not a lot of contractions and things occurring. We want a baseline assessment on mom and baby prior to administration, so I'm looking at maternal status, fetal status, and labor status. And then they may keep the patient on bed rest for a few hours after administration so that the medication can be absorbed. Misoprostol. Anybody get Cytotec in labor last week? So it is a cervical ripening agent. When I'm talking about Cytotec right now, I'm talking about it as a cervical ripening agent. The other use for Cytotec is postpartum hemorrhage. So there's two different indications for Cytotec. You have one use for it in labor. You have another use for it in stage 4 of labor and postpartum. We give very, very small amounts in labor. We give larger amounts during postpartum. Postpartum is for hemorrhage. In this case, we're trying, again, to cause some contractions. The dosage, again, 25 micrograms. It's less costly than the prostaglandin gel. This medication in Med-Surg land is given to patients who have chronic ulcers. It's to help minimize ulceration of the stomach if you're on any type of NSAID therapy to prevent ulcers from forming. It is actually considered a Category X drug. I will tell you that this drug can also be used in large amounts given to women who have a baby that is an intrauterine fetal demise. So if the baby has died and she needs to deliver the baby, and it could be very early. So let's say that the patient has had a fetal death and the baby's only 18 or 20 weeks. They may actually give her very large amounts of Cytotec, which will then cause significant uterine contractions that cause her to deliver the baby. In this situation, we have a healthy mom. There's an indication for being induced, post-dates, maybe she's gestational diabetic, something's going on, we need labor to get going. And so we start with very small amounts, and we don't want to give it too frequently. So generally it's given and then you wait 6 or 8 hours and give the next dose, and then notice you also have to wait to start Pitocin after the last dose of Cytotec. So unfortunately, Cytotec, it's like it's a ninja, okay? It is very quiet and very silent. You give Cytotec, and everybody's like, nothing's going on. Let's give another Cytotec, and you wait, and nothing's going on. And then all of a sudden, out of nowhere, the ninja reveals itself, and you start booming out contractions after contractions after contractions. I will never forget this drug because at my hospital, they were doing clinical trials with this drug, and we were using big dosages of this drug, and we had lots of complications and uterine ruptures and all kinds of fun things. So I have a healthy respect for Cytotec. The big thing about Cytotec, again, is that artificial labor, and contractions will happen, and sometimes the cervix doesn't change at all. Sometimes it does, sometimes it kicks people into labor. The urban legend here in Louisville, I don't know who it is. I think I have a funny feeling who it is, but I don't know, I don't want to say. There is, the urban legend in Louisville is there are some OB providers who write a prescription for Cytotec and give it to the patient and have the patient take Cytotec at home. That is a big no-no, because if you're using Cytotec, you should be monitoring mom and baby. So if you know anybody in your family or somebody says, they told me to take this little white pill, it would make me help my labor start, don't take the white pill. So the big thing was Cytotec is uterine hyperstimulation. Remember with our balloon, we needed to pause. So you had a contraction and you waited, and you had a contraction and you waited. In this situation, we get uterine tetany, and with uterine tetany, there's no break. You get something that looks like this. It's again, very uncomfortable for the patient, very high risk. So then this causes your baby's heart rate to go down. So you can see prolonged decels, so you need to monitor your baby. And then actually, believe it or not, the medication that we use to treat postpartum hemorrhage can actually cause postpartum hemorrhage and uterine rupture. So it's kind of a dichotomy. So anytime I have a patient who's getting any kind of cervical ripening agent or induction of labor, I'm watching very carefully for hemorrhage afterwards. That is a key thing for me. Okay. So these would be contraindications to labor induction or augmentation. So we mentioned placental problems, transverse fetal lie, umbilical cord prelapse, previous classical cesarean delivery. Classical is a vertical incision. We tend to see low transverse, so it's kind of a bikini cut is what we'll see. Phanestoel is the surgical incision that we're more likely to see. They do classical C-sections in other parts of the world. And then the other thing we always have to be mindful of is sometimes the scar on the skin doesn't match the scar on the uterus. So we have to look at medical records to see exactly what happened with that delivery. Active herpes, and then previous myomectomy. A myomectomy is again where they've done surgery inside the uterus. The concern is if there's been any cut inside the uterus, those muscle fibers will not get their original strength back. And so then again, the patient is at risk. Now, this says previous classical cesarean. That's an important distinction, so I would highlight that, okay? So in other words, if the patient's had a low transverse C-section, she may be able to get Cervidil, Prepidil, Cytotec, Pitocin. You just have to monitor it very, very carefully. We want to use as small amount as possible, and we may need some tools to help us be more precise in our administration. So the doctor may want to put in an IUPC to make sure I use just enough of that medication to make the contractions adequate without posing harm to mom. If the uterus ruptures, how would I know that? Again, the patient will be in a tremendous amount of pain. The baby goes into distress immediately. My experience with uterine rupture is that sometimes patients who had epidurals actually didn't feel any pain, but they didn't feel right. It was like something's not right. And you looked in their uterus, and their uterus was not rounded. It was a different shape. It looked different. And we're like, ooh, and there was nothing, you couldn't feel anything there. Kind of felt baby parts, the word baby distress. It was a very gut-wrenching moment. Again, uterine rupture does not happen very often, but when it does happen, it is a medical emergency. You need to do a C-section, and there's the risk that mom may lose her uterus. So then she loses future childbearing. So we really don't want uterine rupture to happen. All right. Induction and augmentation. What's the difference? Induction, you're starting from scratch. Usually with induction, you need more medication and more intervention. Augmentation, you have labor already started, you're just adding just a little bit to it. So I usually don't need as much. Now, our cervical ripening agents help with effacement. So we generally do not use those treatments, those procedures, those medications once she's in active phase. When she's in active phase, we usually are looking at augmentation, and when we're coming with augmentation, the drug of choice is Pitocin, because we need to be very precise in the amount of how much we add to contractions she already has. Okay, so induction, you might have somebody who's scheduled for induction of labor, and it could be Cervidil, Cervidil plus Pitocin, Cytotec by itself, Cytotec plus Pitocin, just Prepidil. There's all kinds of combinations when we talk about induction. Some people come in strictly for Pitocin. So for example, remember, cervical ripening agents, effacement. If you have a patient who's 3 and 75, but she's 41 weeks and 6 days and she's not in labor, she doesn't need a cervical ripening agent. Her cervix is already shortened. She needs to have an induction of labor. They're gonna start with Pitocin. The other thing they might do is break her bag of water. So in some patients, they actually don't need any of that. They just break the bag of water. There's no longer that cushion, so with the contractions you're having, the baby's putting pressure on your cervix and it causes the cervix to open up and dilate. So the indications, contraindications are the same as what we discussed before. So again, if you have a placenta previa, if you're not gonna deliver vaginally, there's no reason to give you Pitocin to induce your labor. Can you induce twins? You can. I have not seen the induction of triplets here. I have never seen a vaginal triplet delivery. I know it does happen, but I have not seen it in my experience. Most of the time, if anybody's over twins, they're a C-section. So sometimes the physician will do what's called stripping the membranes. So with stripping the membranes, it's usually done in the office. The provider will do a vaginal exam and kind of take his or her fingers and scrape the bag of water there to kind of loosen the bag of water separately from the cervix. And again, the thought is that stimulates the production of prostaglandins and can often stimulate labor. So if you have a patient who's 38 weeks, 39 weeks, and she's dilated, the physician or midwife might say, I'm gonna strip your membranes. So what happens after that is you might see an increase in bloody show, you might have some cramping or contractions. Sometimes that progresses into labor, sometimes it does not. In the hospital, we're gonna, the physician or midwife would actually take the little plastic hook and break the bag of water. Once you do that, you're committed to delivery. We wanna deliver within 24 hours. And again, the big thing with this, we're worried about prolapsed cord. And my priority as the nurse is I make sure I look at fetal heart rate before and then fetal heart rate after. And we will pick up on the slide on Thursday.